November pain rounds, and Dr. Zacharias has just arrived. Dr. Zacharias, did you want to do the introduction?
No, that's fine.
You're okay? Okay. All right. So just to let you know that in December, due to the holidays, we will not be having rounds, but we will resume them again in January. So I'm just going to give you a little bit of an introduction on Dr. Punch, although I think really truly it's no introduction, but some of you here may not know him, although the majority of you may. Dr. Punch graduated from the Toronto Faculty of Medicine in 1969, and he did an internship at St. Joseph's Hospital here in Hamilton in 69 to 70. Then he completed a residency in psychiatry at McMaster from 1970 to 1974. And it was during that time that he headed a group of faculty from, it was actually a multidisciplinary faculty, anesthesiology, physical medicine, and rehabilitation, and developed a multidisciplinary pain clinic at McMaster. This was the original pain clinic that was developed here by Dr. Hansen. A number of different professions work in this clinic: physiatrists, anesthesiologists, neurosurgeons, orthopedic surgeons, gynecologists, physiotherapists, occupational therapists, social workers, psychiatrists at the very beginning, and then, the development of the clinic to what it is today. So Dr. Punch was the director of the pain clinic at McMaster from 1976 to 1979, then was the director of the pain program when it moved up to Shedog Hospital from 1979 to 2000. And it was during this time that I met Dr. Punch as his student I did a comprehensive in the physiology of pain at the time. And after that, as they say, the rest is history. And then he also trained me in my career as a health professional, as a psychologist in pain ever since that time. Dr. Punch has done a variety of clinical activities that include pain management, pain relief with spinal cord injury, stroke patients, amputees, back and neck trauma, myalgias, neuralgias, headache, central sensitization, arthritis, complex pain syndromes. Presently, he holds a clinical appointment and a consultant in pain management and in physiatry at the Regional Rehab Center at the General Hospital. He has published in just about every medium of publication that you can imagine: books, chapters in books, journal articles, the epidemiology of pain, psychological, psychiatric aspects, psychotherapy, fibromyalgia, myofascial pain, chronic pain management, evidence-based chronic pain management, and also created pain management guidelines. Dr. Punch is now the president of the Canadian Academy of Pain Management. He has a diplomate with the American Academy of Pain Management, the Canadian Academy of Pain Management. He has received the Lifetime Achievement Award by the Canadian Pain Society in 2006. He received Outstanding Leadership Award by the Michael J. DeGroot Pain Institute. I believe it was at the first pain party for pain in 2013. He also received a Patient's Choice Award by patients at St. Joseph's Healthcare Hamilton in 2014. And it is my great pleasure to present you Dr. Punch.
Thank you very much, Eleni. I am going to be talking about the issues of how to get off opioids rather than get on them. I do have a relationship with commercial interest in the honoraria from Purdue and Paladin for doing some small things for them. And they have given support to educational programs that we presented in the past. The learning objectives are to increase the expertise in identifying the mechanisms and comorbidities and risk benefits in order to choose or recommend changes, choose a concrete plan for management of the pain and withdrawal symptoms, provide pharmacological and behavioral support regarding opioid substitution strategies, to choose a concrete plan to safely rotate from a strong opioid to methadone or a strong opioid to a partial agonist and or adjuvant. and the learner will have the ability to educate and recommend to patients appropriate opioid rotation strategies and institute or supervise the rotation. The changes are induced by continued strong opioid administration, many of them. These are just 3 of them, but there are others. Tolerance sets in, for one thing. Phosphorylation of the opioid receptor, neuromodulation by beta-arrestin, attaching to the receptor and changing the way that the biases in the way that different transmitter systems work. Endocytosis, internalization, receptors disappear from the surface of the cell membrane and reassemble intracellularly, and you can get a larger and larger proportion internal so that they're not available, and the dose required then goes up. And there's a reference there for you if you want more detail. Paradoxical pain can occur, and that's opioid-induced hyperalgesia. That occurs in about 10% of folk, but really depends on the individual and depends on what they're doing. Some individuals are more subject to it because of the way they're going about it or the things they're taking. Opioid receptors connect downstream to chloride channels. They are common pathways for multiple depressants, including alcohol, barbiturate, benzodiazepine, GABA. The active transport of chloride in the chloride channel can become impaired with continued opioid administration, and that can result in paradoxical depolarization of the membrane and increased pain rather than the opposite. So people, for example, can become increasingly agitated, and that is the same sort of process that occurs with the paradoxical agitation with benzodiazepine and alcohol receptors. So there are mechanisms gradually being understood in that, and I've run into other ones too that are a little bit more complex, having to do with modification of the receptor itself. Eventual toxicity to strong opioid can require tapering, and all of these things are possible eventual toxicities. I'm not going to read through all of them, but they include the respiratory, the gastrointestinal, urinary, autonomic reactions, dysphoria, dependency, seizures. A lot of people don't realize you can get seizures. And myoclonus is very common, and seizures are less common, but those are actual effects. Hypogonadism is a very significant problem for males and females with them. Cognitive impairment, cardiac, paradoxical desensitization, as I just mentioned. Withdrawal syndromes, even while taking an opioid, a person may begin to have withdrawal reactions before the next dose, even though the dose has apparently remained level. Itch, histamine effects, or central effects, because itch can come from either one of those. And drug interactions, and many of them, just one example would be benzodiazepine or effects with alcohol. So tapering strategies often begin with just slowly withdrawing the opioid in proportions anywhere 5 to 10% every 2 to 4 weeks, and that usually is manageable by most people, and I've done that many times. And there are various ways to do it with various sorts of agents, but you can do the same thing with fentanyl, for example, because it's a matrix patch. You can cut little pieces off it and just have them go down slowly that way. So it can be done. Autonomic responses, however, can also occur, and that includes sweating, and so low-dose clonidine can be used in that situation. Nausea, vomiting, you can use nabilone or medical cannabis, domperidone, metoclopramide, various things like that can relieve it. Agitation and insomnia, short-term use of low-dose benzodiazepines, 1 or 2 weeks with supervision. There are a number of caveats with regard to the administration of benzodiazepine with an opioid. So while you can do that, some of the caveats are the following. Sometimes for a limited period of time, combined use is not avoidable. So you may like to avoid benzos with an opioid when you're doing the withdrawal, but you may not be able to. For example, when patients are taking the benzodiazepine for a long period of time, and it will take quite a while to get them off, benzodiazepines are needed in low dose to deal with short-term acute opioid withdrawal symptoms. In some psychiatric cases, such as phobias and agoraphobia, you can't just yank them off. And there's spasticity requiring pharmacological intervention. That's probably that email that finally arrived. When considering opioid combined with benzodiazepine, when you do consider that, avoid benzodiazepine if there is a history of paradoxical agitation, COPD, history of benzodiazepine or alcohol dependency or overdose, history of accidental overdose or emergency room intervention for it. Generally, weaning long-term high-dose benzodiazepine has to be done very carefully over several weeks or months, sometimes over 6 months or a year, depending on the situation. For acute opioid withdrawal, the benzodiazepines can be used in low doses for 1 or 2 weeks, in which case the patient should be followed closely, advised to reduce or stop if there's drowsiness or impairment. Hopeful results of opioid tapering. One would expect that lowering the opioid dose or discontinuing will eliminate the risk, and that tolerance will be reversed, resulting in better pain relief, and that opioid-induced paradoxical pain will be reversed. And that can occur, but there are some exceptions requiring refinement of your strategy. Many patients are able to reduce and taper strong opioids voluntarily and gradually without distress, without impaired function. And I still withdraw or taper some people without any additional interventions. They just withdraw very slowly, and you take your time and you go a little slower at the end than you do at the beginning. Others resist even the idea of tapering, and on tapering efforts, they start calling the physician with complaints of intolerable pain and intolerably poor function. So you get a big range in between there. Some patients associate pain and opioid use experience with fear of loss of control of pain and fear of abandonment by prescribers and fear of harm from the new treatment or from actions suggested to alter or change the opioid prescription. And those sometimes arise from somatization, kinesiophobia, catastrophizing, but they all imply there's anxiety about loss of control over pain. So helping the fearful to taper. Psychoeducation, explain the side effects and long-range adverse effects and better probability of improvement with tapering. Anxiety coping skills like applied relaxation, which can be taught in 10 minutes, but it should be practiced all the time. So what you teach people, you don't just think that they're going to do it. You keep checking, and you keep checking how they're doing it. Applied relaxation, changing long-acting sometimes to short-acting opioid will give a better impression of pain responsiveness despite tapering. You get the same dose, but they get the feeling that it works when they get it, rather than the feeling that nothing's working anymore. Interventional and trigger point blocks can improve the confidence. Pain improvement is still possible, and I do, not all the time, but maybe a quarter of my patients I give blocks, just simply to reduce the pain, because it makes a big difference to their confidence that it's going to be okay and something can be done, and I'm not going to get stuck with this. Rotation of strong opioid to partial agonist, gabapentinoid, relaxation, other relaxant drugs or other options can provide more relief also of the hyperalgesic pain. Multidisciplinary programs, such as the one you have here, the group, are considered in the guidelines as an alternative to strong opioid. In some ways that's true, in some ways it isn't true. So I'll make a statement regarding it. Multidisciplinary behavioral treatments, usually initially proposed by Fordyce in '69, have been effective in improving quality of life, adjustment, coping, self-management for people suffering pain. But pain relief is not usually a byproduct of treatment. And access to behavioral programs is limited. Funding is only occasionally available. Often they're located in large urban centers, often have long waiting lists, cannot possibly service the bulk of patients who suffer pain. It's impossible that if every person in a specialty tries to manage pain, that you would have enough. Given the prevalence of 15%, just no one group, no one profession, no one type of agency can really address it all. You can't lose sight of the fact that a substantial proportion suffer significant constant or intermittent pains, between anywhere from 10% of the young to 15 to 20% in the working age, and up to 40% of the 80-year-old. will suffer significant pain. This can't be ignored because it will come up when you're trying to taper, and you have to have some way to think about that and address it and help the person see that it's being thought about. Some cases, pain itself can be perpetuated or aggravated by this strong opioid as a paradoxical reaction. So pain relief can result from tapering, but it occurs in a minority. There are some people who just get so much better when you taper, but a lot of people don't. Multiple other pain mechanisms exist, especially neuropathic and hyperalgesic disorders, and that kind of pain often introduces patients to misuse of opioids. So what to do with the original pain that was there before everything started, and how to manage those with significant drug dependency, misuse, and addiction. And if simple gradual tapering proves not successful, what other alternatives might aid the tapering? So when strong opioids may not be appropriate, many chronic pain conditions such as, this is not an exhaustive list because you can put other names in, other conditions there. Fibromyalgia, chronic daily headache, post-stroke neuralgia, opioid-induced hyperalgesia, chronic widespread hyperalgesia, denervation hyperesthesia, post-Guillain-Barré syndrome, chronic functional bowel pain, small fiber neuropathy usually don't respond well to strong opioids, and in some cases make it worse. These mechanisms may respond better to some anticonvulsants, gabapentinoids, sodium channel blockers, interventional procedures, partial opioid agonist, opioid partial agonist antagonist, SNRI, interventional treatments, and so on. So other things may work. The problem with the WHO analgesic ladder that I was originally taught when I was in medical school, and you were all taught, is that it's wrong. It says that if Tylenol doesn't work, go to a non-steroidal, and if non-steroidal doesn't work, go to an opioid. And that's not correct. In some situations, opioids make things worse. In some cases, the best treatment in extremis is something like carbamazepine for your paroxysmal pain, or infusions for some other condition that doesn't respond to an oral, and so on. So you need to consider what the mechanism is, and always think mechanism when you think about what sort of treatment that you should be giving, because mechanisms are much more important to accurate decision and accurate and good results. In analgesic failure, reassess the patient, identify the pain mechanism, because there are different kinds of neuralgia, and match to the treatment mechanism. Example, with the neuralgia, but with paroxysmal pain, you are probably dealing with injury to myelinated fibers, either inside the nervous system or outside. And sodium channel blockers, such as lamotrigine, buprenorphine or carbamazepine, for example, are more likely to be effective than gabapentin, for example, for the paroxysm, even though gabapentin may help too. But the ones that block sodium channels will be more effective when you're dealing with paroxysmal pain. And that sort of matching needs to go on. Hyperalgesic pain, considered characterized by tenderness, persistent pain, allodynia, punctate hyperalgesia. They're more likely to respond to a gabapentinoid, tramadol, tapentadol, SNRI, TCA, baclofen, tizanidine, injected Botox, topical lidocaine, infusions of some sort, trigger point blocks, interventional procedures, applied relaxation. Those sorts of things may all help various hyperalgesias. And majority of chronic pains are chronic because hyperalgesias get in there. Secondary and central hyperalgesias are generally what drives the chronic pain, and that's why treatments fail, and that's why the pain gets so extreme. And that's why sometimes you could shut it down in a matter of seconds with a block, and shut it down very well for several weeks. The anesthetic doesn't last that long. Innervation hyperalgesias, post-stroke neuralgias, small fiber neuropathies, chronic ischemic pain, when it gets to the point of critical ischemia. These are all neuropathic pains. Chronic ischemic pain where it is critical ischemia and loss of peripheral fiber density. is ischemic, is neuropathic. The combinations that would work with that are various mixes of duloxetine, buprenorphine, TCA, antidepressant for coexistent depression, applied relaxation, things like that. Opioid substitutions for opioid dependency, addiction, methadone is the one that everyone thinks about, and probably all of you have dealt with it at some time. The methadone has a lower relapse rate in an addiction, and it's a stronger mu agonist, and it's easier to find a methadone clinic, and the services are funded. And rotating off strong opioids to buprenorphine naloxone is more unpleasant, more withdrawal than you could experience with rotation gradually over to methadone. And methadone, on the other hand, on the negative side, does not resolve opioid-induced hyperalgesia, craving, or the potential for concurrent abuse of opioid with methadone. Just adding a strong opioid to the methadone, you can do that. And that cannot prevent that. Even though it's positive in some ways, it may not help you in others. Partial agonist-antagonist substitution, the only one that we really have for that is buprenorphine naloxone. We sort of have butorphanol, but not really, and it really is off-label for anything except headache, and it isn't very good right now because it's in short supply and it's almost never available. So I suggest don't try it. Buprenorphine naloxone is effective for hyperalgesia. It's effective for opioid-induced hyperalgesia, for polydrug abuse involving substances other than opioid. People are on cocaine. It helps that sort of problem get better too, and it helps some neuropathic pain better than most other agents. The restriction is now removed for physicians to take a course and get a diploma in order to prescribe it, but funding is still limited. Belbuca is coming out soon. That may solve some of that unless you get money, unless you don't have money for it, because it will be expensive when it comes out. Opioid partial agonist-antagonist substitution is another thing. There is a potential for stabilizing a patient on buprenorphine naloxone and then rotating the dose downward and rotating to transdermal buprenorphine for maintenance. So you start on Suboxone, you get down to really low dose Suboxone, then you rotate them over to Butrans. And that happens, and that works quite fairly well. If you do that, you're going to go from the Suboxone onto a really high dose Butrans and down rather than to 5 microgram. You have to start higher. It's easier to rotate patients from strong mu agonist to buprenorphine naloxone, but quite difficult if the patient takes a high dose of oxycodone. I'll come back to that in a minute. And I mentioned Belbuca is coming out, and that will be useful. Belbuca gives you analgesia at about 1/10 of the dose that Suboxone off-label gives you analgesia. I can get pretty good analgesia for neuropathic pain on a Suboxone tablet, 2 milligram, broken in quarters, and take a quarter tablet 3 times or 4 times a day. It gets really quite good neuropathic relief. You can get relief with Belbuca on 1/10 of that dose. So because of the naloxone in there, still does degrade it a little bit. And so it will be a better option, but Suboxone can be used off-label. Rotation between kappa and mu agonist for tapering. So if a patient has become tolerant to a high dose, for example, a mu agonist and not oxycodone, which is a kappa agonist, it may be possible to introduce oxycodone at a quarter or a half of the calculated morphine equivalent dose. As the mu agonist is rotated down while replacing with the kappa, then you're on a lower calculated dose, and then a few months later, you can go back the other way, but a few weeks later, the person's still tolerant, and you're not going to get very far if you rotate too quickly back and forth. You have to give them a little bit of time for that tolerance to evaporate. It's not going to evaporate in a month. Some of it will evaporate, but not all of it. Rotation between kappa and mu agonist. It's harder to replace a kappa agonist with a mu agonist and very difficult to rotate from kappa oxycodone dependency to buprenorphine directly. It's really quite hard. A strategy for resolving that is to gradually rotate the oxycodone to methadone, for example, over several weeks, and then use buprenorphine naloxone to rotate off methadone in about a 1-week period. So it takes a little longer to rotate over to the methadone and not very long to go. You can, 1 week, you can go off methadone and do pretty well. I've taken people off pretty much between 5 days and 10 days, and good rotation. Example of protocol for introducing buprenorphine naloxone in a patient already using a strong opioid agonist. The evening before starting buprenorphine, reduce strong opioid by 25% to provoke a beginning of abstinence syndrome by the next morning. If they're on fentanyl and they're not in abstinence syndrome, delay until they get into the abstinence syndrome. Most of the time they'll be into abstinence the next day. But if you don't have that, just wait a little bit, because if they're on fentanyl and there's still a lot of it in the system, you can provoke quite a big step down with the Suboxone, a lot of withdrawal, and it's unnecessary because have a day later or a day later, it's not going to do that. And so then 12 hours after you make the initial reduction, you might be able to start Suboxone. So an example would be buprenorphine naloxone 2/0.5, which is the smallest tablet. 1 tablet in the morning, 1 tablet in the afternoon for day 1 and 2. And the next 2 days, it's day 3 or 4. Buprenorphine milligram up to 4 milligram BID for 2 days. And the next 2 days, you may go up to, let's say, 4 milligram BID up to 8 milligram TID, just depending on the situation, how high they were on the other opiate, how much withdrawal there is, how much of a history of withdrawal reactions there's been. You follow it along and you can titrate it. You should accompany it if they have a lot of autonomic symptoms with clonidine 0.5 to 0.1 TID PRN and clonazepam or lorazepam in low dose, and if there is some contraindication or drowsiness, cognitive impairment, then reduce or stop benzodiazepine. But continue the clonidine for 1 to 2 weeks until the withdrawal symptoms, largely the autonomic ones, are resolved, and then you can get rid of it. Reducing strong opioid by 1/4 of the original dose every 2 days until discontinued can sometimes be done. If I've run into situations I've had to get people off quickly. I was pretty sure that they were abusing or misusing, and I didn't want to provoke a crisis, but I didn't know how much they were using, so I could take them down pretty fast. So 1/4 of the original dose every 2 days off, or reducing the original strong opioid first 2 days 50%, next 2 days 25%, next 2 days 10%, and day 7 nothing. And I've done that a few times rapidly when I had to do it rapidly. Yes. Well, they don't like me, but I'm not going to provide ways to people continue to abuse things when I know pretty well that they're doing it. Supportive therapy during withdrawal. The withdrawal symptoms resolve usually by 7 to 10 days. During that time, low-dose benzos, if tolerated, if not contraindicated with clonidine, will significantly mute the unpleasant autonomic psychological distress. And I usually have the scripts written before and ready at the pharmacy. Applied relaxation taught in practice with the patient before the rotation gives the patient an increased measure of control. Tramadol can help weaning from strong opioid. That's another thing to think about. Patients often become chronic due to the addition of hyperalgesic mechanisms or due to neuralgia. And strong opioids are not particularly helpful for the hyperalgesias and neuralgias, and in a minority of cases, the opioids can aggravate them. Tramadol is a partial opioid agonist that's more effective in hyperalgesic states and neuralgia conditions. In fact, if people get on to tramadol for analgesia and they're stabilized on it, you give naloxone, there is almost a not measurable reduction in pain relief, because most of the relief from tramadol and Nucynta is on the effect on the glial cells and the astrocytes and the on the hyperalgesic mechanism. So you really, the opioid part of it is not very important, even though you have to be aware it's there. Tapentadol, or the Nucynta, is also a partial opioid agonist. It's coming into its own a little bit more now, and it's going to be seen a little bit more. It's greater mu agonist affinity, and it's a stronger adrenergic than serotonergic effect. And it appears to have efficacy for hyperalgesic states, and it largely, that and Cymbalta are pretty much at the top end of what calms down the astrocytes in spreading central hyperalgesic pain. Dart et al. Reported in Pain Medicine 2016 that there was less diversion risk of tapentadol. If you look at that report that people do quote, and it managed to get into literature quite a bit, that's really pretty bad study. The data is worse than soft. And most you can say looking at it is that tapentadol and tramadol both have a relatively lower affinity for the mu receptor, that exert most of their effect through the glial cells, that co-administration of naloxone has minimal effect on the analgesia, that tramadol or tapentadol can be abused. Experience is that they are more effective, nevertheless, for hyperalgesic neuropathic conditions compared to strong opioids. So if pain relief is necessary, then consider that as another option, that instead of not giving them any pain relief, you look at if gabapentin doesn't work for you, if carbamazepine hasn't worked for you, if the tricyclics haven't worked, then consider the partial agonists, because they can. And they can do a better job with the things that make pain chronic, including hyperalgesic conditions. There's a recent healthcare warning, February the 22nd, 2017. Tramadol should be avoided in those under 18 or over 75. It poses possible risk for supermetabolizers who have a much stronger mu agonist effect than expected if they can't, if they metabolize the whole thing. If all of it goes to the metabolite. You try to limit co-administration of benzodiazepine or alcohol with tramadol, tapentadol, buprenorphine, because these increase the risk of toxicity if you take alcohol with it or benzodiazepine with it. In some countries, people like Egypt and Lithuania, Latvia, the country Georgia, Egypt, street use of tramadol or buprenorphine mixed with benzodiazepine and injected is the street drug. It's the way to do things on the street. The World Health Organization estimated in Egypt, where there was a practice of doing that with tapentadol, with tramadol mixed with benzos and injected. They looked at death rate. Death rate with those groups is 1% of incidence of overdose. So even then, it's less fatal and less dangerous, for example, than our fentanyl that we deal with now. But it can be abused, and so you should be aware of that, and you should take precautions that it isn't being diverted or misused. Tapering is usually not enough. In any opioid tapering or rotation, psychosocial support, behavioral input, counseling, treatment of depression, they're all important ingredients. Without them, you're not going to get anywhere. Now, I'm going to be able to stop for discussion, but I have another slide deck here if we need it. The other slide deck is the pharmacology of partial agonists and how they work and why they work and the properties of them, if that comes up as a necessary thing. But we may have had enough on the table here that we have enough of the discussion. So I'd open it for discussion before we do any more.
Thank you, Simon. Do we have any questions from the audience, the remote ones? No? Okay. Any questions from the field? Any comments? Thoughts?
One, you might ask, do I know what I'm talking about? I've done this about 200 times. I did. I looked at my files. I've done it about 200 times. There are two people who said that they were worse after I took them off the strong opioid and used buprenorphine. Two said that their life was worse. and all the rest of them said it was improved. Yes.
You've answered my question. How do you break through at the beginning end when you feel it's going to be finished by the patient? What do you mean to reduce the opioid use? Do you say this on the
Generally, I give them the facts. I say, I'm not in a hurry. It's your life. I'm telling you what's happening. What I am telling, I'm not going to preside over you increasing it, and I may not be able to preside over you continuing it. And things are coming down. If I'm in the absence of me, you may not get anything. So you better look at it. The second is that the other thing I'm telling them is that you very well may be in a situation where the opioids you're taking may worsening the very thing that you're asking for help with, and you would do better in other treatments. Somebody is trying to get on? No? No.
I have a question.
Yeah.
So you've been at this for quite some time.
Yeah.
How do you think medicinal marijuana fits into this whole equation in your extensive experience?
We don't know the properties of marijuana yet, because there has not been a randomized control trial with a purified strain of this or that enough. We have lots of randomized control trials of marijuana as exists in the way the grower gives it, and some of it shows that some people benefit from it. Not enough that we are in a position to advocate for it or tell our patients, you would do better on this, and that person would not do well on this. So it's there. I think the truth of it is that we are going to have to live with the fact that marijuana will become legalized and will be out there, and people come walking into whether you like it or not, whether you agree with them or not, they're going to come walking into your place and say, okay, you're giving me this treatment, but I'm accessing marijuana, so now what? And I think you're going to have to know how to address that. So my position on it is be well informed on it and know what the risks are and know how to mitigate risks. And whether or not you advocate, I don't advocate it. I don't think we're at a position yet to advocate it. We just don't know enough about it. We don't have a proper trial and won't be able to have a proper trial until it's legalized enough that the drug companies get a hold of it and get purified amounts of it and do actual double-blind randomized controlled trials and in samples of patients that actually tell us something. Yes.
I wanted to make a comment. So one of the methods just certain offering genetic testing of cancer. So most likely so you have patients who are interested and so how much do you capitalize cancer? I don't know the details. I certainly know a lot of I just think it's one that can be really had an effect on the use of the drugs in the public place.
Yeah, and it's very hard to predict who belongs to what group. Yeah, yeah, and that's the point. So until you know that, it's really hard to advocate.
Most of what we do is trial and error anyway, right?
Well,
try it and see how they do it, right?
Yeah, but you can get around the drugs that we know a lot about, like these ones here I'm talking about. We know the mechanisms enough that it isn't really trial and error. What I'm doing in my clinic is not trial and error. I have a reasonable bet that somebody comes to me, let's say a paroxysmal pain and damage to a nerve, more likely than not, that's going to respond to a sodium channel blocker, and it will not respond to some other things like something dizanidine, for example. So we know that. So it isn't trial and error, but yes, there is a certain amount of trying things out, and some things will work better than others. It's not working blind. I really don't. I don't at all accept the notion that we're going blind and trial and error in that way. Yeah. I do, but not often. I do ultra low dose naltrexone. It is 0.001 milligram per day. 0.001 milligram. 10 nanograms per kilogram. You sure is. It takes all day.
Oh, thank you. You probably some of you are aware that Mr. DeGroot just funded establishing the Center for Medicinal Cannabis Research at McMaster. It just got launched 2 weeks ago. So we're in the process, and I'm the medical advisor, that in the process of identifying what studies need to be done. One of the early studies we're doing is there's a belief that there's a sexual dimorphism, certainly has been demonstrated in America. The suspicion is it might be demonstrated in cannabis. So there's going to be a study starting in the new year looking at male and female rats, the CBD oils, and some are involved with it. So there are a number of projects that are being funded for it. I think we'll get a much better understanding of how this product actually works over the next little while. And one of the reasons I got involved was the same mistakes that we made with the opioids. I really don't want to repeat it here. Because I see, as an investigating coroner now, a regional coroner, I get things on my BlackBerry every single day, multiple times, for drug overdoses in this province. So when you look at it, we right now have almost doubled the number of drug overdoses that occurred in the last year. So we're just starting to understand some of the errors that we made earlier on in prescribing opioids, which is now translated into the illicit drug market. The problem with the coroner's data is it doesn't differentiate between prescriber, prescriptions to illicit use. And now they're trying to drill down the public health Ontario as well. So I'm encouraged that at least some people are now starting to look at cannabis right up front, whether it's from the clinical side or the basic science side. As a prescriber, I can tell you, you look at it, certainly there's empirical stuff about lowering people's opioids. But even when they switch from one license producer to another, often it doesn't work. So it's quite interesting. If people talk about genetic testing, I'm involved with Corner on genetic testing on sudden cardiac death. How do you predict who has the genotype and the phenotype that produces it? And I'm sad to tell you, genetic testing is not great. It's just not great. In fact, I'm not sure the person who says, I thought I was Scottish, and now it turns out I'm German, actually is so Scottish, because the genetic testing is not that accurate. But yet they're standing up there saying they have determined that I'm no longer Scottish and I'm 25% Indigenous. When all of that testing, I can tell you, is turning out to be bogus. So I'm just telling you that a pure genetic testing is not the answer, because it actually hasn't been investigated so far, including pediatric cases. I have a pediatric case of pulmonary hypertension in a totally normal 2-year-old. Genetic testing of that is ridiculous. We can't hang our hat on genetic testing to solve all the problems. But I do think that we're learned from the past, and now I completely agree with Eldon. We need to know this better before we jump on a bandwagon and completely utilize it, and God knows who's going to do it. So I think this university, I believe, has an opportunity to lead in actually studying this product much better. So I don't want to discourage all of you. Genetic testing has a role, but I think we've given it way more credit than it actually has turned out to be in reality. Certainly in the death investigation system, it has not turned out to be what we thought it was going to be. So, but I do think cannabis is going to turn out to be good, but I think the way it's being prescribed right now is crazy. And some of you who are in the room know one of the people that looked at this on 32 marijuana a day. That's 40 joints. How do you eat? They're smoking 40 joints a day. This was prescribed overnight. So that's something that is crazy. So I think we're trying, I think some groups trying to better control.
Clearly, it is potentially able to do something.
Correct.
And so we can't ignore that. The other part of it is that the receptors are vanilloid receptors. The vanilloid receptors are widespread in the peripheral and the central nervous system, just about everywhere. And in the cannabis, attaching to these receptors in some places is activating, and in some case is suppressing. And so it's very difficult to predict what these things do. Plus, the samples of marijuana that we have, even from the same producer, month by month, can change in their composition. There are 50 or more active products in the marijuana, and that proportion changes even with the season, even with you stay with the same producer. And an independent study of that was done in Washington State 4 years ago, where they took 17 samples from different providers, and they looked at the ingredients, and they found in one case the ingredients actually corresponded to what was advertised on the samples of it. And in Canada, the Globe and Mail did the same thing last year, and they found that of the 10 samples that they were assessing, 0 had in it what it said on the label. And even though the growers had submitted it to labs, which had said, now this is what the proportion is, next month it might not be. Yes? Yeah. For what? Yeah. I refer very few people. The ones that I mostly have referred are people who are fairly high users for a long period of time, and more likely than not are dependent on it for as part of their coping. There's a couple of 3 or 4 people that I follow are paraplegics or quadriplegics, and they felt that it doesn't help the pain, but it helps the discomfort of spasticity. And I've tried to facilitate their getting it because it does help that. I think for the most part, I tell them, listen, we don't know enough about it yet for me to make a referral for you to go anywhere. We just don't know. And at this point, there's a lot more research need to be done before I, as a physician, would recommend this or that. So I'm not telling you that I will be annoyed with you if you come back with it next week, but I'm telling you that I'm not going to be the one who refers you to something where I really don't know what it's going to do, and I don't know whether it's right for you. Yeah. No, they looked at about 10 different things, and one of the things that they looked at was what the ingredients were. They had a whole bunch of things.
So no, and I think, you know, we often have mixed feelings about cannabis, and there's really a confusion here. So dispensary cannabis is extra legal outside of the system. Completely different from licensed cannabis, which is assayed to like 10% violent THC CBD. They can tell you by genotype plant theirs and what plant it is. So just quite important to clarify that. I think also, getting folks hooked on cannabis is a concern, which is why we have a screen predation that's I just wonder, though, whether it's a bit of a false parallel between Canada and
Well, they're not parallel at all. Yeah. They're completely different mechanisms, and so, no, you can't make any parallel. It's apples and oranges. Other discussion?
Sorry, I'm looking for the sign-up sheet that went around.
You had a question before. Did your question get answered?
Yes, thank you. Just to again tell other colleagues who are working in anesthesia board, my question was if patients come from buprenorphine patch and pre-op clinic, how we deal with that at level, are we stopping in and doing something doing or not?
And I say no, don't just you go on. You will find that it will block the oxycodone more significantly than others, but the buprenorphine patch doesn't block anything enough that's really going to change what you're going to do. You might need to up your mu agonist a little bit, but don't do anything else. If they come not on buprenorphine patch, but on Suboxone, and let's say a history of addiction, there was more harm to take them off than to keep them on and just adjust upward the opioid. Where you might run into a little bit of antagonism is where you are planning to give fentanyl. And if you're planning to give fentanyl, there is more problems with the Suboxone. And so I tell people who are not addicted but are using it more for the anti-hyperalgesic effect, if they're going to be going for procedure, find out from the people who are doing it whether fentanyl is going to be used. And if it isn't going to be used, just do nothing different. And if it's probably going to be used, then I'll take them off the fentanyl, off the Suboxone for a few days and give them morphine, low dose, or hydromorphine or something like that to prevent any withdrawal. And then I put them right back on after. And that won't mess it up. 7 days is enough to wash out that effect. But you make a better guess if you don't really know, just keeping them on what they're on and just adjusting upward what you're going to get.
Anybody come on board from the remote audience?
Nothing came on, no.
No? Okay. So, any other questions? Just to remind all of you, not to forget to fill up your certificate of attendance and to complete your evaluation form. Oh, sorry.
Well, I just want to know what you guys think around. I'm just curious in case I have a picture.
It degrades somewhat the effect of the fentanyl. When somebody is already on Suboxone, it degrades it somewhat. It doesn't stop the strong opioid from working. It will work. It's just not quite as much. So if you have somebody come in and you know that they were already on Suboxone and you haven't really had a chance to discuss it, go ahead and do what you're going to do. But watch what you're doing in the induction, and if necessary, you can give a little more. It'll work because the strong it is an antagonist, but it isn't a complete antagonist. It antagonizes oxycodone much more than the mu receptor. Okay.
Make sure you sign the sheet so you get credit. And there's an evaluation sheet here as well. Just fill them up.
And I just want to get